All right, everybody, thanks for joining us. This is our second follow-up session on autism spectrum disorders with Dr. Schoenwald. It's also our last learning community session for this 2-year program. I'm going to go through a couple of items before Allison gets going. I have your full attention. I just want to start. We have no financial interest to disclose at this session. And so, like I said, this is the last learning community, but your kind of work in the behavioral health program is kind of far from over. A lot of you are recently adding behavioral health providers or are still on that path. So you'll be working closely with your integrated managers to kind of continue to build your behavioral health program. But there are other opportunities for you as clinicians and staff at practices to participate in this program. So the first are advanced learning series. So these are continuing education opportunities on various behavioral health topics. Some that we touched on in this learning community and we delve into a little bit deeper. Others are topics that have been brought to us by folks like you who we've gone out and gotten speakers in and developed content that are interests related to this material. So here's the agenda.
I can say preview a little bit about what the topics are.
Thank you.
Yeah. We're planning, we're aligning speakers now. There's going to be a session on assessing and managing suicidal behavior. There's going to be a session on behavioral support for kids with chronic medical illness, how to provide that kind of, support for all the psychosocial issues that surround serious medical illness. And those are the two that I know that we have set for sure.
So these wouldn't be a repetition of anxiety, depression, ADHD.
No,
done with
it won't be a repeat content. It'll be new content. It might be a topic that was, touched on here, but maybe a different, a different look at it. But so keep an eye out on the weekly roundup email that goes out, because as these are developed and scheduled, we'll have registrations in there, and they're a mix of in-person and online participation as well, right?
Yeah, they are a mix of there's online participation, and they'll all be taking place at Children's Hospital in Waltham.
Terrific. And teach rounds, I think all of you are aware of teach rounds, but these occur twice a month. They're an opportunity for you to present a case and get real-time consultation from the experts in the field that you either had present to you, like Dr. Schoenwald, and just be part of the audience, so you can hear your colleagues and some of the questions that they have, and you'll probably say, "Oh, I have a patient just like that," and hear what guidance they receive. So those happen twice a month, and again, those are in the weekly roundup. The case descriptions in the roundup, so you can see what is going to be presented, and you can tune in. And it's another way just to kind of stay tapped into the community that you've been part of over the last 2 years. Do you have anything to add, Jessica, for this?
All good.
Okay.
And I think that, if you haven't been asked to present at teach rounds yet, you will be. That's part of your,
yes,
participation in the community
yes.
To do that, and it's a great opportunity to get consultation
We're
from
matching practices with dates.
the really rich team of clinical consultants from Department of Developmental Medicine and Department of Psychiatry. And when we have enough lead time on a case, we can get specialty consultants from specialty departments. We've had specialty consultants from the adolescent substance use program. We've had, I remember on a case about suicide, we had some experts from
Munchausen by proxy.
Yeah.
And then, so, you guys are just finishing the learning community aspect of this program, but believe it or not, we're launching phase 7 in the fall. And this one's a little different. Some of you might be upset that you signed up for phase 6 because these are all going to be online in phase 7. But we're really trying to get folks from practices that have already participated in this, that have already completed either the first year of the learning community or both years of the learning community, to get providers who haven't participated yet to join, because we really believe that the more clinicians that are kind of attuned to the model that we teach here, are able to really kind of build an integrated behavioral health model in their practice really, really well. So the more providers that we can get to go through this, we think that you can be more successful. So if you have some colleagues at your practices that you think would be interested, please let them know that we're going to launch the 7th series in the fall, in September. And again, the registration brochure has gone out. So they can either just sign up, or they can reach out to me or their practice consultant, or Alex or Jonas. There's a bunch of people that they can participate in. Jonas, Lucy, you going to say something?
I want to reemphasize something you already said, which is really important. You know, we've launched integrated behavioral care in 40 practices now, and I really have seen a difference. Practices that have more physician participation in this learning, the model takes, you know, shape in a different, sort of more robust way. The more engagement, the more people in the group that are involved in the learning, it really is qualitatively different, and they're succeeding in sort of seizing a fuller piece of the opportunity that we have as we integrate mental health into our practices. So I will, again, repeat what you said, encourage, you know, you all to encourage those in your practices that haven't participated in this learning to do so, and we've really made it quite easy for everybody to do that remotely. So that we're all sharing in this and working to change the way we provide care together.
All right, great. And yeah.
If you sign up for all, or you could just pick what you want?
So this is like signing up for the learning community again, right? But if you are like, you know what, I really want to kind of tap into like the anxiety module again, then by all means you can participate in just a module if you want to. Okay.
And will we get the links to get into those?
Yeah, the links will be sent out. So I guess we'll have to make sure that we send them out to prior
Okay.
Yeah.
That would be
prior
great.
participants as well too.
They're
Okay.
also, aren't there YouTube?
We do
tapes?
record them, yeah. But you know, if you want to be live, so you can ask questions
Yeah.
and hear it, just a different feel.
And you can get CME credit.
Yeah,
If it's live, you can't get CME credit if you're watching a recording.
you can't get it. Yeah, you need to watch it live, exactly, to get the credits. Okay, and then the last thing, and then we'll hand it off to Allison, is so for CME and MOC credit requirements for this year for physicians. So here's the outline of the things that you need to beat. So for both CME and MOC, you needed to attend 5 of the 7 in-person sessions. I'm going to skip over the second thing there, but you need to complete the post in-person sessions for those meetings. So if you attended and complete the surveys, you let us know, and we'll let you know. You can finish those up. You need to complete the QI coursework related to the learning community. So this stuff's been sent out. I think to date we have coursework from 3 practices, and that's just, you know, planning a very kind of brief quality improvement project. So if it's around screening, if it's around follow-up treatment, medication management, whatever you kind of found of interest in this learning community, and you thought that you had an area for improvement, you had to run a short test for that. So do an intervention, and then just report out how you did. So I'll follow up with the requirements after this meeting, but that's another requirement for CME and MOC credits. And then for MOC credits, if you've met the in-person requirements, then there's a provider attestation. You should have them in the in-person sessions, and if you're remote, we'll make sure we get them out to you. And then the last piece is a reflection survey, which will be part of the survey that goes out today for MOC credits, and the coursework to do by August 2nd. All right. So that, I'm gonna hand it off to Allison.
Great. Thank you. Happy summer. Almost.
Not yet.
Almost.
Tomorrow.
Nice to be here. We are doing Autism Spectrum Disorder Part 2. I changed the plan up based on the responses to the surveys that you provided after the last session. So I thought we'd actually start with some follow-up that's really directed at the questions that you asked. So screening tools, there was a fair amount of question about that. Psychopharmacology requests to sort of have a more in-depth conversation about that. I will say that we're going to talk more about that today in the context of adolescents. But there was also a fair amount about getting the evaluation and the treatment, about engaging with parents around the diagnosis. So we'll cover that. And then we'll spend the time remaining on adolescents with autism spectrum disorder, the management, and the whole transition piece. So the first question, and it came up pretty clearly, is why did I mention the MChat when you have the SWIC, which has the POSI in it? Why did PPOC not make the MChat available in EPIC? Well, I do want to disclose that I am one of the authors of the POSI, but I certainly, I've not been involved for 15 years and get no financial or anything. So the MChat is on the left side when you're looking at the screen. The POSI is on the right. The MChat is for autism only, but the POSI, while it can be standalone, you're getting it with the SWIC, which is a whole system of screeners that cover behavioral issues, developmental issues, and family function. And so the POSI comes in the development. I will say that part of the SWIC benefit is that it has developmental screening that is free, that's included. The POSI is clearly shorter, 7 items versus 20. I think that probably the sensitivity, specificity, sort of the accuracy issues of the MChat are better defined. There are more studies using the MChat. It's been used longer. The POSI has two validation studies that I know of. One is just looking at kids who were referred, so they're already coming in because someone had a concern. So it's not necessarily as robust of an evidence base, but while I was not involved in why the PPOC chose it, I would assume that it had to do with a larger question of what makes the most sense for practices and using the integrated system with a tool that clearly seems to be adequate for autism made a lot of sense. So I don't think that Jonas is not disagreeing over here.
No, I think it's clinical efficiency. I think it was the driving factor.
Yeah. So I don't think you're missing something by doing a POSI versus an MChat, which is the POSI I think you experience probably as part of a SWIC. I'm not sure it's so clear when you're doing it that it's the POSI within there. Just like, pediatric symptom checklists and, are sort of in the SWIC. So I don't think you're missing something. I don't think that you should feel remiss. I think it's a reasonable clinical decision, whether I had been an author or not. I think time will tell. But as I was writing this, I was thinking, it's all about you, though. It's all about asking the questions and looking at the kid and thinking about the kid, because none of your referrals are based on the results of a screener alone. So getting the information from the family is the most important thing, whether it's with your 20 questions or 7. And then it's making your clinical decision. How does the kid look? What is the family saying? Is this a typical day? Is it not? Does he do fine at preschool and have tons of friends? Or do the teachers say he really doesn't? It's sort of part of the bigger picture. I know at the last session, it was hard to have group conversations. So I'm going to keep going right now. But if you have a comment or a question or want to say something, please use the electronic system. Raise your hand, write in a comment. I'm sure I'll know somehow if there is a comment.
We will, yeah. It'll pop up here.
It'll pop up, okay. So please go ahead and do that if there are more questions. By the way, both of these have plenty of translations. Neither has tons of validation in other languages, but many tools are not validated in other languages. And when they are when they do validation studies in other languages, more often than not, they end up being valid. But more importantly, if your choice is, do I use it even though it's not validated, or do I not screen, you should go with choice A. I think you want to make an interpretation based on cultural or language differences, but you're making an interpretation no matter what.
How long POSI? Because I've never heard of it.
The POSI is that, it's just the 7 items it takes.
When did it come out?
When did the POSI come out?
Yeah, because I didn't know about it.
Well, the SWIC is what's in EPIC. Have you heard of the SWIC?
It's
The
embedded.
POSI is in the SWIC.
In SWIC.
It's one of the sections, one of the components of the SWIC.
Okay.
Yeah. So
It looks like it says 18 months.
No, that's the age range.
Yeah.
You want to know when, right? I think we wrote it probably in about 2006, and I think it was validated maybe 2012-ish. And then there was another recent study where they compared it to the MCHAT, but again, in a referral population. So there's not a lot of literature. So another question was, what is ABA, like what skills do they actually work on? How does it work? So this is a slide that has information that was mostly in the last session, but I'm going to go over it maybe in a little more detail because clearly there were more questions about it. In all kinds of ABA, applied behavioral analysis, the same sort of tenets drive this, the same framework of how they teach kids skills. So the first is just remember, applied behavioral analysis is about actually teaching kids skills. As opposed to a sensory diet, right? If you think about that, that doesn't teach you skills, right? If that means that you swing or you take a run or you hug something tight and you feel calmer so that you're more ready to learn, you're not actually learning a skill, right? You are feeling calmer. You might be learning how to use a tool to self-calm. This is actually teaching you specific skills. And it's always teaching you through reward-based trials. So what does that actually mean? For discrete trial training, it is very structured, and they would teach one small skill at a time. So the therapist decides with the team, including the parents, what are our goals, and they're usually very basic goals that are building blocks to something bigger. So when we see kids for the first time who are really not engaged, hard to get their eye contact, hard to, they're not necessarily learning the things, they're just sort of engaged in looking at the things that are interesting to them or repetitive behaviors. For them to learn, they need to look at you and they need to imitate you. That's how kids learn. The teacher does it, the other kids do it, you imitate them. So if we decide as a team that imitation is going to be one of our goals because he's not going to be able to learn other things without that. Let's say we pick a car and rolling a car, and now I want you to roll your car. So first they decide what is going to motivate the kid, what's going to reinforce that behavior. We try to avoid food, which is sort of a last resort, an M&M or a gummy. So we want to do, they do preference assessments and they figure out what's going to motivate a kid. Some kids it's a high five, some kids it's computer time if they're older, some kids it's, getting to, I was looking online last night, getting to play the piano. Just every kid has a different reward. And the therapist is sitting at a table or on the floor with the kid, and I might have my car and say, okay, zoom, you do it. And now the kid has to do it. If the kid doesn't do it, then that therapist has some hand over hand and helps them do it. And then they take out the card and say, okay, you do it. If the kid starts to approximate it, touches the car, maybe they get a reward. And they keep doing it and 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 doing it. And the therapist is taking data to see when the kid finally imitates that.
And when you talk about doing it and doing it and doing it, this can take years, not just
Well, if you're working for years on imitating a car.
No, not the
right.
car. You progressively more
Right.
complex
Yes.
interactions, but this is a long, that reinforcement cycle
Right.
is a long,
Right.
it takes a long time.
Right. So learning these skills is going to be longer, right, than certainly a typical kid. But typical kids don't actually need to be taught in a structured way to imitate. They just do it. And that's one of the differences. So discrete trial training is boring. Kids don't necessarily like it. It is incredibly effective in building those skills.
No, do they teach them, the parents,
Do they
have the same thing at home?
So the question is, do they teach the parents the same thing at home? Well, if your ABA is in school, no. If you go to a center-based program, then there should be a parent component. And ideally, yes, ideally parents observe some of it. Ideally, if you're on an IEP, that top grid, that A grid, has parent-teacher consultation, and that would be one of the things you would want to be sure is in the IEP that parents can learn. There are also plenty of YouTube videos and plenty of books that they can get, and plenty of websites with free parent training for this. There are some pure training models for parents, but it's too time intensive. It hasn't been found to be feasible. It was sort of thought that would be helpful for people who are have less access. So what's interesting is sometimes you have a parent and you feel like this parent is all over this kid. And they are, and sometimes they've sort of been doing intuitively ABA all these years. And we come in and we feel like a kid has had years of ABA, they just didn't know it. But the mom was like constantly, not always the mom, but usually constantly doing it. And you look and it looks so abnormal because it looks so like in their face, but actually that's what they're doing sometimes. I've had mothers actually then go on to become ABA therapists because it's really, they just sort of get it.
I had some family from Japan, and there it's required that parents have to spend 1 day a week.
In Japan, the programs require the parents to spend 1 day a week. I think that the best models and the evidence says that parent involvement is one of the components that makes a model effective. It's a required component. The issue is just feasibility. Also it's really very hard on your relationship with your child if you're the therapist, if you're the one making them do this over and over, because your job is to love them and love them unconditionally. It's hard. It is hard to do this as a parent. Pivotal response training is a kind of ABA because it does work on specific skills and it does use reinforcement, but it does it very differently. Everyone in California does PRT. Everyone in Boston does discrete trial training. That's just how people were trained. They should sort of know how to do PRT. PRT is harder. So the skills that they're looking to work on are not that discrete looking at me when I call your name, but it's generalizing a skill. So it's a skill that you have that the goal skill is now to generalize that. So the generalization becomes the goal, or the spontaneity becomes the goal. This is much harder as a therapist to teach. It's easier for me to get an assignment. I'm going to teach eye contact, and I'm going to do it hundreds of times until the kid does it. It's boring, but it's straightforward. So young people right out of school, discrete trial training, they get their hours for certification because it takes hours to do this. You need to be much more skillful and sort of be able to be flexible, because pivotal response training uses the child's interest in the activity as the opportunity. So if I'm trying to teach generalization and I want the kid to spontaneously ask using 2 words, and the kid likes tickling, and we're playing a tickle game, then I'm working towards, in tickling, him saying more tickle, right? And maybe first if he says nothing, I hold back. If he said then I tickle and I reinforce it, but I'm reinforcing it with the activity that he likes. That's related to what he's doing. The more tickle is related to the tickle. So the reinforcement is related to the task. The task, right, is saying more tickle spontaneously, right? I'm not saying say more tickle, and he says more tickle, right? He has to come up with it, but I'm setting up a situation, right? You can start to see this is harder. This is much harder to do, but it would be one of the things after you have all those discrete trial trainings that you move towards, right? So once you have some of those basic building blocks, you move towards PRT. So I hope that gives you some sense of what ABA is, because I know from your questions that was one of the sort of lingering mysteries, like what are they actually doing?
I was always happy to see the results of ABA, how much different the child is, but it's so good to learn what they actually do.
Right, so the comment here is that we've all seen nice results, not everyone, But when you see it, can be dramatic. But that sort of understanding what's actually happening. Why is it 30 hours a week, ideally? That's why.
30.
More than a part-time job for a 2-year-old. Most 2-year-olds can't tolerate 30 hours, right? But 20 hours or more is what the literature has as the best evidence for results. So it's intensity of hours, it's individualized hours, parent participation, parent component. Those are 3 of the factors that play into the best outcomes. I'm not sure if there's any discussion at other sites, like we're having a touch of discussion here that I am reflecting back to you.
Yeah, any comments from Bridgewater or CHA or Springfield or anybody else? I think there's a couple other people online. So feel free to chat any questions, or you can unmute yourself and just chime in.
This ABA program, who introduces the child? Is it the school? Is it the parent? Is it the physician? Who says, oh, go for this?
So the question is, who introduces or recommends that ABA be implemented? So usually the evaluation team, whoever diagnoses the child, it should come with a list of recommendations. If you are diagnosing a child, and some of you are, and it is a kid who is really not doing these building blocks, not answering to name, not looking at you, then you recommend ABA. You are not going to be wrong. If it's a higher functioning kid, so I saw a 4-year-old last week who mom always knew there was something, he always looked great to the pediatrician, but over time, he's 4, he loves microbes, and like he has unusual interests. He finally has a friend, but he's never been a problem, right? It's been subtle and sort of lurking, and we actually didn't recommend ABA for him because he does have these sub-skills. He just needs to really focus on those social engagements and those play skills. So the kids who are really very impaired with very little skill set, when you see them, those are the kids you can recommend ABA. The kids you're not sure, then I would let the evaluator.
What I notice is they improve their social skills and interaction, but not the language. They're still not talking or speaking.
Right. So ABA doesn't always help. You can work on those social communication skills, looking at you in the eye, imitating, things like that, but they don't always help with language. Some kids have a real language disorder, right, within their autism. And some kids with more skills, have sort of a framework for the language to develop onto. But it's not speech therapy, right? So they need speech therapy also with it. And ideally there's some sort of, communication. Parents can self-refer. If parents go online, they'll see ABA for autism. It has to do with whether insurance will cover it without a medical diagnosis written. So they might ask you for that, or certainly they would, as specialists, we write letters of medical necessity for ABA.
Allison?
Yes.
Bridgewater has a question.
Great.
Thank you. If the diagnosis for autism is pending because a psychologist has done a workup, but we don't yet have a report and a formal diagnosis, can the PCP request ABA services and have them be covered? Somebody said they had a situation where the insurance wouldn't cover it because the diagnosis everything wasn't settled yet with the psychologist.
Had the parents been told the diagnosis is autism?
Yes, based on just the MCHAT in the pediatrician's office.
Right. Do you know if the psychologist diagnosed it or didn't?
No, pending diagnosis of by the neuropsychologist, I would say. It was just a failed MCHAT twice.
Okay, so I think there's sort of 3 steps. The first is, if you see a kid and you want to make a diagnosis, you make your diagnosis. I know that we talked about this last time, that we're becoming, a broader range of behavioral specialists. This is a time that your integrated behavioral health provider can work with you also on being a second set of eyes, observing the kid, agreeing, not agreeing. You can write a diagnostic letter giving the diagnosis. It wouldn't be a tentative or a, pending. You can diagnose and you can recommend ABA. They might not all give you ABA as a general pediatrician writing this. If you write that you have experience, you've managed 2,000 kids with autism, you have an experienced behavioral health provider who looked at the kid, you reviewed it at teach rounds maybe with us.
Have specific training in the learning community.
Yes, you write something and then you describe what the kid does. He does not respond to name. He is constantly engaged in repetitive behaviors. He has serious sensory sensitivities. There's a strong family history of autism. You write a letter that that defends your position, right? So you can do that. Can't promise it will work. With Mass Health, there is a tool that they require, the CARS, which is a very easy to do. It's just a survey that you fill out yourself from observing the kid, and you report a score. You have to buy it. Many people it's not a great tool. Mass Health picked it. I wasn't part of that. But Mass Health requires either a CARS or an ADOS to have this. And so that's a problem. But if you are a practice that feels very strongly and very invested in this particular thing, you can order the CARS online and do that. I think that the other thing is we're not diagnosing autism based on an MCHAT, right? So as part of that diagnostic picture, you refer to your MCHAT and the scores, but an MCHAT alone doesn't diagnose it, right? Lots of kids have a failed MCHAT who do not have autism. Lots of kids with language delays, and some cognitive delays will have a failed MCHAT. So PCA has never had a child diagnosed with autism receive 30 hours of ABA. They wonder why. So I'm going to finish my thought and then I'm going to go back to that. So the first is you can write a letter and do your best. You can call the medical the medical director of the insurance and argue your case. You can try that. The second is this a kid who has had the visit with the psychologist and doesn't have a report yet, or is still waiting for an evaluation?
Bridgewater.
This is Bridgewater, yes. Bridgewater, you're muted right now.
1 minute. Sorry.
That's okay.
Go ahead.
Yeah, we are waiting for the evaluation because, it was like 8 to 9 months with the neurodevelopmental.
Okay, so he hasn't had an evaluation yet.
No.
Yeah, right. So, so I'm going to get to another question that came up about that, about waiting. But I think that if you haven't had an evaluation, that would be your best bet of ABA, is if you write the letter. So the question that just came up was,
Recent diagnosis.
oh, why are you not getting 30 hours in your
hours,
practice? Okay, so you're not getting 30 hours depending on, there are lots of reasons. Many kids do not tolerate 30 hours. It's too much, right? I mean, they do a couple hours, even 4 hours a day, 4 days a week is 16 hours. So, and that's a lot for a lot of kids. The big issue is if they nap still. Kids who are napping in the afternoon, it's very hard to get in more than 10 hours, 15 hours a week because they're napping. Obviously, another issue is the supply and demand issue where the agencies simply don't have enough therapists to fill the hours. So insurance might actually say 20 hours or 30 hours, but they don't have enough therapists to fill the hours. Especially if you're in a more rural, area with less access. There are some insurances that, that will approve a certain number of hours, though Mass Health does not have a limit. The ERICA law said they can't, there isn't a limit to the number of hours. I think some people often write in reports 10 hours because they don't want to set the family up for failure. They feel like if I write 20 hours and they don't get it, they're going to feel like they're failing to do what the kid needs. my personal opinion is then you're not even giving them a shot at fighting for 20 hours. You're sort of contributing to a two-tiered system. If people you don't think can get it, you don't even recommend it for. So I personally wouldn't rate that unless I thought that was the right number of hours. Some kids go now to center-based programs. And again, if you are in an area without center-based programs, you're not getting this. But those kids can get 30 hours where they're basically going to a place instead of school every day, all day. And they're getting tons of ABA. And they, can be very effective. And they do try to make it look more like school where they have circle time and they have snack time and lunch. Some of those places do have typical kids there as models. They're often siblings of the kids who attend. And some of those places, they take insurance, so it's paid for by insurance. It's not by your school. The problem is that some of those places, I think for their own staffing, only take kids who are there full-time. So to get that intensive center-based, you have to decide on that or school. And that seems very business-driven and not clinically driven. I think it's harder to staff that, unevenness in hours. It's easier to staff. Everyone's going to be here all day. That's how many people, that's how much insurance, that's how many staff, that's how much salary. The problem is it's just not clinically driven, right? Because we want kids, let's just say halfway through the year. It turns out they don't need a full day. They should go to their local public school for half a day, and they should stay at the center for half a day. That they won't let you at some of those. So I think, that's going to work itself out one way or another.
The advice you gave, to write for what they need, not what you expect. And then, you might write 20, 30 hours, but then you say to the parent, listen, I'm writing that because that's what you need, but you may not get that. Set the expectation there, not in your recommendation.
Kids,
right.
That he was getting the twice a day. She was coming to their home. So she comes back and he said, "You back again?" I don't want to.
A little girl who, right, she sees the therapist coming and says, "You're coming back again?" Because that therapist is making her work, I bet. Yeah, so the downside is even when we do try to set the expectations, people don't always hear it or remember it. And there is a criticism, of specialists that you write 20 hours for everyone, 30 hours, and no one can get it. And then they feel it's a problem. But I think, again, the clinician should be writing what they actually think the kid needs and then to support the family through it. So many questions after the last session. I cut and pasted. Any suggestions how to help parents cope with such long, I'll assume you're emphasizing and not yelling, wait time to see developmental medicine, evaluation resources besides developmental pediatrics, availability of services, and wait time for appointments. So there's no way around it. The supply and demand issue, it is across the country. It is at every academic center. And when academic centers double their staff, the wait time goes down for a year or two and then goes right back to where it was. I think as a community, it would be helpful if we stop people from getting on every list to see which one comes up first. Because think about all the administrative time and all of the clinician time that is lost in figuring out those lists. So it is a travesty, I think, to be a third opinion unless there really is a lot of question about it. So I think, that's one thing we can do to contribute. I realize, parents have a right to be on as many waiting lists as they want, of course. So it's not going to get better unless the models of care change, which I don't see necessarily happening at academic places anytime soon. Developmental pediatrics, more people retire every year than match in the fellowship programs across the country. So those numbers aren't viable for long-term life, right? I mean, it's, and truthfully, I wonder if part of the burnout is living with these 2-year wait lists on people's backs. It's exhausting. So yes, this is a big problem. And so you asked for some other thoughts about what to do. So I have some thoughts for you. I mentioned the May Center for Autism Evaluation and Treatment in Randolph. Now, I think that I didn't mention any other academic institutions or private practices. So there are many academic institutions that do autism evaluations locally and in the state, and there are many private practitioners and private group practices that do autism evaluations. Some take insurance, some don't. So that's one option, but the May Center is, I think of it as not, it probably is a private practice, but I think of it as more of a school, generated from a school, the May Center school. And what's nice about these evaluations is everyone gets an ADAS and a cognitive, and so that's always, and they always have a letter for ABA medical necessity, and I think they're pretty accurate. What my experience is they don't provide, as far as I know, long-term clinical care or follow-up. So it's often a one and done. I'll tell you that in 24 years at Children's, I saw lots of kids who had a May Center evaluation and report. They all look the same, but they have the scores, they have what you need for, and I always agreed with the diagnosis. And so then they wait on these long lines of Children's. We do the testing again and then follow them, right? So that's one thought for you. I don't know what their wait time is now, but it's generally because they don't do a lot of follow-up, they don't get full.
There are so many May centers.
There are many May centers, but there's if you go there, the places for the evaluation and treatment are not all over. They're like there's one or two places, I believe.
So it's diagnosed for them, the expectation of ABA is followed through. We would be following up with them.
So the question is, who follows up with this child if they only get their evaluation and they don't go back? Well, again, there are private practices that will follow. Some take insurance. They can wait online now for their long, wait online to go to one of the academic centers. They'll be getting treatment. They'll get retested, and then so you can do the interim until they get a developmental. So let's just say you see a kid, you refer to the May Center and to Children's, or and to Tufts, or and to Lurie, whatever it is, and they wait on their long list, but they go to the May Center, they get their diagnosis, they get treatment. You are now the one doing it with your behavioral health provider until they get their evaluation in 9 months, 12 months, 14 months, 18 months at their academic place, and then they can take over from there. So that would be an option. Not ideal.
Behavioral health provider.
I think your behavioral health provider in your practice, they're not going to be supervising or monitoring an ABA program, which you aren't either, but nor am I. It's really to have a check-in. How are things going?
Okay.
Are you accessing your
Not
services?
specialty care, but
No.
check-in, yeah.
It's monitoring,
Bridging.
it's partnering, it's bridging.
Supporting.
Right. Which honestly is a lot of what the developmental pediatricians do. We're monitoring, we're supporting. I mean, I'm not managing their ABA program. I'm not looking at all their data. I mean, sometimes I send it. I don't know how to look at this. It's like graphs and grids
But
and
it's the
numbers.
relational piece.
Yes, yes.
Is there a structure that we could follow of what is to be checked? Like, is there something some information we could have to say, okay, if we go down this path for a child that's waiting for a formal, academic diagnosis, are there things that, like roadmaps for us that we could use to say, yes, these things are being done, we're sort of moving along?
Right. So the question is there a roadmap or some sort of protocol for bridging care? Not that I know of. I don't think that's out there. I don't think that would be hard to create if that would be helpful. It wouldn't be, evidence-based or, evaluated. I think that it will look a lot like what you would be guessing, Any concerns from the parents? Is he getting the services? Do you have questions about the services? You can't answer the questions, but then you can say, did you ask the ABA person who comes every week? And they say no, more than half the time. So why don't you go ask her and say, why are we still working on eye contact after 3 months? Ask her that. Maybe she has a good reason, or maybe she just needs a nudge. So you're looking, are they getting their services? Are they making progress or not? Are there new behavioral problems? What new questions have come up? And the new questions that come up are also going to end up being a pattern that's recognizable. Well, my mother-in-law doesn't really think it's autism, and she thinks it's sensory integration disorder. What should I do? And you have the answer to that, which is, We had this evaluation, they recommended this treatment. Let's keep doing this treatment. And when you get to your specialist, that would be a good question to ask. Unless it was something that I had said, right? If they had said, do I really need an audiology evaluation? You would say, yes, you really do, right? You actually know the answers to this. You've just been trained to think you can't answer it, but you can. I mean, that you're not supposed to answer it, but you know these answers. So I think that's a good question and sort of not unreasonable to do.
You know, in addition to monitoring and continuing to educate and helping them advocate, you know, just simply asking, how are you coping with this long, you know, how are you doing with this? That feels so supportive to families when we take that moment to ask how they're doing with it, you know. And that connects back with that question of how do we best support them during this period.
And how frequently, like, would you recommend checking in between when they have this evaluation and they get hooked up with the academic center? Is it like patient by patient basis, or is it like, you know, once a month or once every 2 months?
Yeah, so I think that after a first diagnosis, a 2 or 3 month visit is really just for, I say, come in, write all your questions that come up and come in with 100 questions. Come in just, and we'll just do questions in maybe 2-3 months. If they're sort of, they've got it together, they have a plan, they suspected it, it could be 6 months, you know, it would be, and they'll call if there's a problem. What ages and do they start evals at the May Institute? I believe it's 2, which, you know, might be part of the issue, but I'm not sure. That's a good question. I think it's 2.
And for the folks who are thinking of, like, you know, doing this model and then just touching base with the parents, this is where your MHCC can tie in and use population management reports and Epic, and you run that report, you find out your kids who have this diagnosis, and you find out when their last visit was. Yeah. So do we have to get, you know, do we have to have a phone call or get them in for a visit or something like that?
So some secrets to getting the evaluation faster. Tell the parents to say on the phone, I will take a cancellation. Because you know what happens to 2-year-olds? They get sick. And they have fevers and they vomit, right? And they don't come in, right? So tell parents, I will take a cancellation. That can help. It is very inconvenient if you have a job, but then the parent's going to just have to call in sick that day, I suppose. I don't have a good solution. I understand that can put their job in jeopardy. I don't have a good solution to that, but if it's an option. You know, can a grandparent take the kid and the mom's on the phone during her lunch hour and break time? I don't know. And then the other thing is that once kids hit 3, the IEP evaluation should provide services. I understand should is the pivotal word there, but there's actually no law that says to get autism services at school, you need a medical or a formal outside autism diagnosis. It doesn't, there's no law for them to say he can't be in the autism program until he gets a diagnosis, against the law. The law says the IEP services, right, are for kids who are not accessing the curriculum due to a disability, and that the disability and the progress will be sort of remedied or supported through supportive services at school. So you have to have a disability, you have to not be making progress in accessing the curriculum, and that has to be responsive to some treatment. Okay, but it doesn't say who has to give you the disability diagnosis. And schools might say, well, we can't diagnose autism. Fine, don't diagnose autism. See that he's got delays in language and social and, you know, making friends, and give him an IEP that addresses language and social and making friends. They say, well, he's got to fit into a category. Okay, put him in a category. Well, he needs a doctor to make the diagnosis. No, he doesn't. He doesn't. So they sometimes do what's called an educational autism diagnosis. So you can ask the school to do that. I will tell you they're not always accurate. I've had kids with intellectual disability who have an educational autism diagnosis and really don't have autism. But you know what? They're in small classes. They get ABA. It's structured. It's actually a very good program for them. So, you know, the goal is that they get the services that they need. So that would be sort of another thought when you're fighting that wait time. But of course, only for kids who are 3 and over. I think this is a really vulnerable group because I can't count the number of times a family of a 3-year-old went to a local school only to be told, oh, he can't go to school until he's 5 by September. Because it's a well-meaning front desk person, and the parent didn't say autism or didn't say IEP, they sort of didn't use the right words. And then they come back in 6 months and I can say, what happened? They say, well, they told me you can't get it. And I'm like, right? So I think that's a place that we can maybe be specific. This is a slide from the last session. While you are waiting, you can be doing your EI referral and helping connect the family to services, or of course IEP if they're older than 3. Make sure there's a hearing test. Every kid I've ever seen was referred for a hearing test, but many kids never actually made it to the hearing test. Books and activities. If you have not used the autism word yet or they're hesitant, this Hanen website just talks about interventions and supports parents can do. It doesn't actually have the autism word in it. And then the Early Start, this book does have more autism, but it's using everyday activities to help kids connect, communicate, and learn. I think that's a very accessible book. You can get it on Amazon, and you can say, look, I'm not sure this is autism or not, but what we're talking about is language, communicating, and getting through the day, and I think the strategies in this book will help no matter what. And you let them off the hook. It doesn't have to be autism, but I've had some training in this, and this has been recommended as a very good book. So you can give them some things to do. They can give it to their daycare provider. They can, this can be helpful. Someone's asking for about the RITA screening tool. So that's, I think, at UMass. That's, I think, Rula Chueri's screening tool. It really, I think that it's one of those sort of evolving, emerging screening programs. So it hasn't sort of made its way necessarily, as far as I know, to the eastern areas of the state. But, Rula is well trained. She's had a good fellowship, if I do say so myself. And, she's become a well-respected leader. So, I think that it's, again, all of these diagnoses are about getting a good history and doing good observations and making sort of an informed judgment. So I think it gives a structure to that. And so I think it certainly seems like a promising thing that could sort of gain traction.
Can I just one question? How does it start first step? Somebody has a 6-month-old or 9-month-old. We are not sure if it's still could be in a normal range. How do you refer them? Or what do you do?
Right.
First step in
So the question is, what about very young kids, 6-month-olds, 9-month-olds? Is that what you mean?
Yeah, and the first step in this direction.
So the problem with 6 and 9-month-old, like you say, is that some 6 and 9-month-olds look terrible, and then they just sort of wake up and they look fine. And so there isn't necessarily a diagnostic tool that accurately tells you which of the 6 to 9-month-olds are going to have autism. So some of those kids will. You're more worried if they have, 3 older brothers with autism, right? And now they're not answering to their name at 9 months and 12 months. But that's a problem, right? So I think that you're not referring those kids. Well, maybe you are, so they can get on the wait list. The youngest kid I've ever diagnosed was 14 months. And she's very impaired. She's now about 17, very, very impaired. So I don't know. I think that you validate the parents and you watch with them, and you share their concern and say, I think that parents, I think what we want to say is, oh, he's just a baby. He looks fine. Lots of babies look like this. And then parents end up feeling like no one listened to them. Mm-hmm. And he might be one of those babies that he ends up being fine. And most of them probably are. It's just that we don't know which ones aren't. And so I think we say, I hear what you're saying. But we know that kids this age, it's hard to know, right? But you're seeing something, I'm sure that you're seeing something real. You can refer them to these books. I think what we recommend for those parents is really getting in the kids' faces and sort of forcing the relationships with them. So these are the parents who are, can I touch you?
Yeah, sure.
Who are saying, Brad, hi, it's mama, it's mama, right? And they're doing it, Brad, it's mama, it's mama. And they're doing it, and those are the kids, the parents look like they're in their faces. But the kids, I think that's the best we have right now. I don't think we know better what to do for those kids.
Because the sooner you start, the better the results are.
Right, so the sooner you start, the better. But it's the sooner you start with a known diagnosis, the sooner you start with autism. And I guess the question is, do these kids have autism or not? And I don't know the answer. Some of them will, some of them won't. Moms look back and often say, I did not feel the same emotional connection with this child from birth that I did with the other kids. Moms know a lot. But they don't usually say that when they're 10 months old. They don't usually say, I don't feel emotionally connected, unless they have older kids who are typically developing and they say, this one is different, there is something different. And then again, you put them on the list and you're encouraging this sort of in your face stuff, get early intervention in there. But I think we are not there yet with the clinical care or science to know exactly the best thing to do.
Yeah, I think early intervention is a good place that I do. They do a good evaluation. They say, no, this baby is fine. So parents feel good, but we'll watch and follow. But they do help.
So early intervention,
one way or
right,
the other.
right. So I think early intervention is another set of eyes, right? Is another person to walk the walk and partner with the parents as they move along, and either the kid's going to look better or not, and that's going to sort of tell where the story is going. But I just don't think you always know. I have seen 6-month-olds who were so not engaged and didn't answer and didn't look and in their own world, and I was like, oh, and then they're fine. I mean, we've all seen that, I think. And we just don't know which they're going to be. Okay. So I'm actually on to sort of the next section, and this was one of the questions. Teenage years are my most challenging in managing, possibly with less support. So any input would be helpful. So I'm going to take that challenge and run with it. I do want to say there were a few questions that I ended up not touching because they're whole lectures. Like the current research on autism was one of the questions. I wouldn't do it justice to have a slide or two and help you feel prepared to answer that. I think that if that's an interest that you have, you need to tell PPOC that you'd really like an update on the research of autism, and that would be probably a different session. Okay, adolescence. Typical kids with adolescence, right? They are forming their identity. They are taking risks. They are separating, from families that they're going to be ready to be off and into adulthood. They are, often finding their friendships and their social circles, their most pressing issues more important than anything else in the world. It is a tricky time. I think many people look forward to having a baby, but very few people look forward to having a teenager. Right? It is not an easy time for parenting generally because it is not an easy time to be. I don't know if any of you think your teenage years were the best years of your life, but most people don't. The 20s were much better, right? And that's because you were past this trying period. Then on top of that, we're not talking about autism, we start seeing the impact of learning disorders as school gets harder with more volume. ADHD becomes a bigger problem. Again, the executive function demands of high school, the driving risks, the social nuances. We start seeing higher rates of depression and anxiety. This is why you're doing your screens every year, because these are high incident issues. Kids are much more aware of family stress in a very concrete way. Kids, when they're little, they sense it, of course, but kids who are older, they know. They often know what is happening. They know we're going bankrupt and what that means, or they know that mom caught dad cheating or dad caught mom cheating, like in a way that 4 and 5 and 6-year-olds only know there's a problem, right? So they start knowing about stuff. Then, of course, we get the substance abuse risk. So this is my visual of adolescence, right? It's hard. It's just a tumultuous time. It can be a wonderful time in many ways where kids have much more grown-up thinking and abstract thought and problem solving and want to start making the world better and creating projects, right? I mean, you see the flip side, doing wonderful things for their friends and their teachers, right? You see them sort of rising to the occasion because of these issues. But I think most of them also have a fair amount, well, many of them have a degree of anguish at the same time. And then you get autism on top of it. So you have all those things, but now you've got your teenage patient with autism. Well, one complicating issue is, where are they developmentally? Where are they in the developmental trajectory? Many kids do have an IQ that is of average or higher range, but a large portion, a disproportionate number of kids with autism compared to the general population, will have a lower IQ. So how does that play into these demands of adolescence? It does, right? Because if you're supposed to understand, manage, and decision make, right, and your cognitive level is going to impact that if it's low. Even when your cognitive is on par, as part of your autism, social skills often lag. So you see a lot of kids with autism, who teenagers with typical IQs, who don't know why they don't have friends, who don't know why other kids don't like them, who want to have a friend and don't know why they don't. And then some of them do struggle with the abstract and hypothetical regardless of their IQ. They're very concrete. These are kids, you say, what would the walls say if they could talk? And they say, walk through me, right? That's a very concrete answer, right? What I'm asking is, imagine the walls had ears and they heard what's going on in the room. What would they, right? Which you don't usually have to teach, like no one ever taught you that. You just got it over time. So my daughter yesterday, she had dark humor. She said, it turns out in times of crisis, I have dark humor. She's 10. And she did. But her 10-year-old best friend had no idea what she was talking about, dark humor. Like, she wasn't there yet to get what that was. Right? So it's part of your trajectory. And with autism, you often see a real struggle with that. Okay, then the environment is changing a lot in your teenage years. High school is far less structured. No one's in the hallways. You're supposed to know your schedule. You're supposed to know where your locker is. You're supposed to know what to bring to your next class. You're supposed to know where your class is, right? Right? They're not, my fourth grader, every other week, I get an email with all the other parents about what are the dates to know in the next 2 weeks, right? What are the field trips? What are the permission slips? What are the, right? You don't get that in high school, right? You don't get that. Also, they don't have behavior charts. There's no there's marble jars that they're doing in elementary classes when the class does something good or someone has good behavior. Teachers often have a marble jar. They put a marble in the jar. When the jar is full, we have a marble jar party. I mean, there's some variation of this in many classes. Or you earn, if they catch you being good, they give you a homework pass. You can use any time this year, one night. You don't really get that in high school. There's no more incentivizing it. You're expected to work to get your work done. Some of these kids, remember what I told you about ABA? It is all reinforcement dependent. To the extent that I have a kid who, before we understood this, had such fabulous ABA his whole life, and now at 26, he would go to a job at a day program and they would say, would you do this? And he'd say, no, thank you. Didn't work, right? Because there's no incentive. They're not going to reward him at 26 in a day program. And that starts in high school, right? No incentive. And it's just more unpredictable, right? Part of the beauty of elementary school is it's very predictable. The days have a structure. Every Friday is music. Every Thursday is gym. And now in high school, what are they on, an 8-day schedule? So every Monday is different for 8 weeks, right? Right. It feels much less predictable. And then, of course, the evolution of comorbidity that I just mentioned is probably increased in this population. So more anxiety, more depression, more bipolar, more schizophrenia. But it's really the anxiety and depression, that really just jump out. but that yet we miss because we sort of attribute them to all the other things, and we probably underdiagnose and undertreat anxiety and depression in the whole population of people with developmental disabilities. So again, this is another good place to work with your team in your office. I think it's a good idea to have teenagers with autism have a check-in, just to see how it's going and be screened for some of these things, so that we don't miss them. So what does it mean? What should you be doing? So this was one of your questions about medication, and I thought we'd go through it with a case. This is a kid of mine who, at 10, came in. He has an autism diagnosis. He has an unusual MECP2 duplication, a normal to high IQ. He's in regular classes at school with some ABA and autism specialist supports and some social skills and some speech, but he just has this catastrophic thinking. He is very upset, very stuck, gets very stressed and worried. He's a kid I'm always racing to be on time, because if I'm late, he gets very, very anxious. If there's traffic, if there's any stop in traffic that's not a red light, he loses it. He's just getting very, very stuck and worried. He's very edgy and repetitive, and nothing satisfies him. No plan, even if we leave early, even if the parents say, we have 2 hours, right? We have 2 extra hours. We're going to be there in time for lunch. Like, nothing makes him feel better. And that's really getting in the way. So let's just say we reviewed everything. There's no trauma. There are no other changes at school or at home. There's nothing else to explain this. It is him developing, a new anxiety issue. You've ruled out everything else. He's not ill. There's no new medicine, right? No new teachers, no kids left, no bullying. There's nothing. So we're not looking to take more history. We took a great history, and we're left with this emerging anxiety. Not surprising. These are 3 different studies in the 3 columns. The rates of anxiety on the top here, and then OCD in different groups of people with autism, much higher than the general population. There are certainly medications that we can use. So many of you are using medications to treat typical kids who are developing some anxiety or depression. You use your algorithm, you've had your anxiety training. It's the same group of medicines to think about in this group. It's off-label, right? Because first of all, there's no generalized anxiety indication for children or adolescents. There are indications for OCD. So it's off-label in that you're not diagnosing OCD. On the other hand, there's plenty of experience with all the different medicines. I think that, Celexa is an option, right? We don't really use Paxil anymore, but Prozac and Zoloft are probably your first choices, given that at least we have indications, down to 6. Lexapro is down to 12, and I think we don't really use Luvox very often lately. And I think the rule of thumb is start lower, go slower than typical kids. So I know many of you are probably not comfortable with this, but if you're going to start exploring it, I would think about it in a very similar way to your typical population, and I would just start low, go slow. No one ever regretted going too slow. We've all regretted going too fast. What does that mean? I would take the smallest dose. So let's say fluoxetine, it comes as a tablet with 10. I would break that in half and start with 5. And instead of going up every 2 weeks, I'd go up every 4 weeks. I just start half the dose and go twice as long. And am I making this up? Yes, but I've done it for years, and I've taught this around the country because there isn't a better algorithm out there to tell you better than I'm telling you, that I know of. For sertraline, the smallest tablet is a 25. I would break that in half or even a quarter for someone on the slight side or the younger side. So 6.25 for 3 or 4 weeks. See how they're doing. What are the problems going to be? The biggest problem is going to be kids who get disinhibited, who get more explosive or more emotional, and then you stop it. So that's why I would do Zoloft probably before Prozac, because Prozac will have a much longer half-life. It will take a much longer time to wear off if it's not good. I think this is a good time to team with your behavioral health provider, right? These are kids that could use phone check-ins, that could use in-person check-ins, see how it's going. But I think the experience of it doesn't tend to be that different from the experience of putting typical kids on SSRIs. It just feels a little more anxiety provoking to us. So again, there's a good amount of evidence for a lot of these medications, SSRIs and a few others here, for children and teenagers, for OCD, for generalized anxiety, for social phobia, all of the anxiety disorders. So I do tell people it's off-label because it's approved in this age group for OCD, but that there's a lot of evidence and experience in their more generalized anxiety. And that's what I did with Andrew. I put him on sertraline. He couldn't swallow a pill, so I started the liquid. He remained on 10 for quite some time, and he just could move from topic to topic more easily. He didn't like it when there was traffic, but he didn't sort of lose it. And that's what you're looking for. You're looking for someone to be more responsive to talking, to thinking differently, to using calming strategies that they've worked on in therapy, right? You're looking for them to sort of, instead of being way up here in their intensity of reaction, for it to be a bit better. You can use your anxiety scales. There certainly are some scales out there specific to autism, but I can't say that they're terribly well validated or certainly well used. So most people use the regular anxiety scales that you use for all your kids as a general way to monitor. Again, you're not monitoring based on a number, right? A number is part of your bigger picture of how you care for the kid. So again, he's your patient, so he keeps coming back. He's been on the sertraline for a couple of years. Anxiety's been manageable. And now for the past month or two, he's become verbally aggressive. He sort of postures to his mom, right? And she's sort of slight and he's getting bigger. He makes threatening comments. He makes threatening looks. And he'll have these screaming outbursts in an airport when the plane was late. And right, just bad. He's not a bad person, but it was very upsetting and it had gotten problematic. And it was just becoming more and more frequent. It wasn't just a phase. And these are, again, you rule out everything else. Let's say for the purposes of this talk, no changes at home, no bullying, no medication changes, no nothing. It's just this. This is just his autism, and his adolescence. Now he's bigger, he's louder, he's stronger. And it looks worse to have a screaming outburst as a 13-year-old in an airport than it does to be a 4-year-old. Because every flight I've ever been on had a screaming 4-year-old at the gate. I don't know about you, but they follow me around. Okay, so maybe talk amongst yourselves for a minute. Do you want to increase this? Well, what do you think should happen? What would you do, or what do you think should be done, or what would be your best guess of someone doing, if not you? Increase sertraline, switch to a different SSRI, add guanfacine, add or switch to risperidone, add or switch to aripiprazole, which is Abilify, or get a pharmacogenetic consult.
All right, so we're going to mute ourselves real quick. We're going to chat here, Bridgewater, CHA, and Springfield. You guys can chat, and then we'll come back in like 2 minutes, maybe less.
want to do anything else?
The,
All right, we're back.
Okay, so CHA tells us that they would add guanfacine, which was also an answer we got here in Brookline. And CHA, do you want to tell us why you would start with guanfacine?
You can either unmute yourself or you can write that in.
Hello, can you hear us?
Oh, yeah.
Oh, hello.
Hi. Well, I think my preference is, I think, one, it's safe medication, good safety profile, risk of sedation, which wouldn't necessarily be bad in this clinical circumstance. And I think probably the most effective tool for reducing the impulse and aggressive behaviors with a safer profile than the antipsychotic medications. The other consideration was increasing the SSRI if that needed to be as an adjunct. The medication's been well tolerated in the past, so I don't think it's an issue with the SSRI. So rather than changing to a different SSRI, I would think about increasing the dose of the current one after the guanfacine is on board.
Does anyone feel strongly? So you said first guanfacine, then increase sertraline, but Springfield said increase sertraline or add guanfacine. So does Springfield feel strongly about which to do first?
The one's reasonable.
Either one.
Either one. Yeah.
Well, we know that sertraline works, and it may work better if we increase the dose. We know that guanfacine helps with aggressiveness, so we are sort of open to suggestions. Which one would be the first to modify?
And so, do you think that increasing sertraline might help?
Yes.
Do you think adding guanfacine might help?
Yes.
Okay. And so let's think about what is going on for him. So we did the sertraline because he was having this sort of catastrophic thinking, right? And worries and anxiety, and it helped. Now he is threatening and posturing and making aggressive threats. What is that?
Could be because of anxiety.
So we think maybe it's from anxiety, but we actually didn't say that in the history. It's not like they're stuck in traffic and he starts to get aggressive or posture, right? Now we have something different, right? Where, yes, the plane was late and he had a major tantrum. So maybe there's some anxiety there. Okay. Any other thoughts about what is going on if it's not necessarily anxiety? What is your guanfacine treating?
Aggression.
Aggression. And where is his aggression coming from?
His anxiety, depression.
Okay. So he's frustrated, right? But I get frustrated a lot and I don't get in your face and posture usually.
Not always.
Right? So he's frustrated. Why is he doing this?
Usually.
Oh, he's a teenager and he's developmentally delayed.
He's a teenager, so he's developmentally delayed. He doesn't necessarily, well, he's got a normal IQ though.
Yeah.
Right?
Yeah. But socially delayed.
He's socially delayed, so he doesn't have that social pressure to have appropriate behavior. And he doesn't necessarily have the social thinking skills, right, to understand and then manage the environment. Right? So in a very simplified term, this is autism, right? I mean, this is an expression at some level of his autism, why he can't do some of these things, that he has these responses that are atypical.
Yeah.
So there's no right answer to this question.
Correct.
Right? I mean, it isn't should you do sertraline first or guanfacine first. I think the answer is you should think about what you're doing and try to do something that makes sense, that's low risk, as you said, and likely to be effective. What if I told you he wasn't safe? Mom didn't feel safe with him alone anymore. Dad had to be there all the time now.
Well, I think about a more sophisticated assessment and getting EMH involved if there's a real immediate safety risk. I think then I would really want to get either a phone or a face-to-face psychiatric consultation.
Right. And what are they going to tell you on the consult?
I'm not sure. I mean, they might make the recommendations that we just made, that perhaps you'd be put on an antipsychotic, but I'm not sure that's something I'd be comfortable starting.
Right.
If that was a concern. I would, and referring to EMH is just going to get an assessment about whether he needs to be in the hospital or not. It's not going to really get me any closer to a prescription.
Right. So they say, of course, he's fine at school with the supervision and structure we had there, and he's fine with when dad's there. I just make sure to always have another family member there, or dad can work from home, or dad can come home, right? Right. No one wants to go to the emergency room.
Right.
So I think certainly if you get a good story that these events are triggered by anxiety, stress, worry, but stuckness, not necessarily. Stuck thinking is autism. It isn't always anxiety. If he gets stuck on a thought and can't let it go and everyone tries to calm him down and then he explodes, I'm not sure that's anxiety, that's more autism. The guanfacine, yes, can help your impulsive behavior. I'm not sure how much of this is impulsive as opposed to what you said, he's frustrated, he doesn't have better tools, but then as part of his autism, he becomes very dysregulated, disinhibited. So guanfacine, in my experience, is often the next step, but often only lasts a brief time, helps us calm things down for a while, but ends up not being enough, and we end up still needing more help. So I have a number of these kids on an SSRI and guanfacine that lasts for a year or two, and then it just gets worse again. But that's okay, because we had a year or two without an antipsychotic, and that's a really good thing. Sometimes I feel like my whole job is being a wall between a child and antipsychotics, right? Because it is the easiest, fastest thing to do that is going to settle this down.
What about counseling, therapy to help him cope with this?
Right, so the question is counseling or therapy to help him cope. This young man actually has a very good therapist who is, believe it or not, very experienced in kids with typical IQ with autism. I mean, it was really like he already had it. I think, though, at the moment of explosion in the airport or posturing, I think those kids aren't really able to access the skills of therapy because they just went from 0 to 100. So there's lots of reasons we see self-injury and we see aggression. It could be the impulsivity of ADHD. It can be the irritability of a mood disorder. Like we said, it can be the anxiety. It could be psychosis. There can be environmental issues, which we just said in this case weren't the case. The frustration that you mentioned, they're afraid and they don't know how to manage that. And it can be a combination of some of these or many of these. Sometimes I find myself drawing a picture for parents with some of these words in it to say, these are the things happening. We're targeting the anxiety now, but we've never treated the ADHD. Or we're targeting the anxiety, but in the wrong environment, it's not going to help, right? And I sort of draw a picture so that we have a plan based on the things contributing. I think antipsychotics come up in this moment. Here's a sample comparison chart. These are all of the side effects, like that you mentioned, the considerable side effect profile. And here are the sort of original group of second generation antipsychotics with clozapine in there. And what you see in terms of the side effect profile, ziprasidone, the brand name is Geodon, so ziprasidone is the generic. You see, a high rate of prolonged QTC. And as pediatricians, we don't like anything wrong with your heart or EKGs. We like to stay away from that. Clozapine, an older one, lots of sedation and weight gain. Olanzapine is Zyprexa. Again, lots of sedation and weight gain, not what we're looking for. Quetiapine also, maybe a touch less, but olanzapine is Zyprexa and quetiapine is Seroquel. Seroquel they use in hospitals for elderly people for sleep. It seems like overkill sometimes, but it's very sedating. So we're left with aripiprazole, which is Abilify, and risperidone, because really they have the lowest side effect profiles of our choices. So again, here are your choices. And the aripiprazole and the risperidone are the only ones with FDA approval for autism. They are approved for irritability, aggression, self-injurious behavior, tantrums from autism. They don't affect the core symptoms of autism, but if you think about this young man, right, irritability, explosion, aggression, right, this is, so while we want to avoid atypicals as long as possible because of the side effects, if it's, you know, the only way to stay home and not be in a residential, right, it's probably a better choice. If you're, you know, so impulsive, you're jumping out windows and running across streets, it's a better choice than that, right? If your younger siblings are traumatized growing up in a house with your unpredictable aggressive behavior, you know, there are lots of times where it is the right choice. But I agree that the only pediatricians I know prescribing are either people who did specialty training or people in very rural areas who have no choice, who have no ABA, who have no autism classes, who have no psychiatrists, you know, for 100 miles. You know, there are pediatricians in the country doing this, but they're not happy about it. And they're in much different situations, I think, than we are in Massachusetts. So I don't know. I mean, maybe one or two people here prescribe antipsychotics in the office. Not one or two. I mean, there are a handful of people in our region who do. The monitoring suggestion I have, you know, is pretty intensive. There isn't necessarily a uniform monitoring plan. You'll see that many people just prescribe without monitoring anything, no blood tests, no EKGs, but I don't. I would be much more aggressive about it. And it's helpful because if I'm not sure it's working and your prolactin is, you know, 25, or if I'm not sure it's working and your LFTs are 2.5 times normal, I'm probably not going to go up on the dose. If I'm not sure it's working and all your labs are rock stable, maybe I will go up on the dose, right? So it sort of helps me make decisions about my next steps. So with Andrew, I do think I tried guanfacine for a year or two, but then we ended up on Abilify. A quarter I usually start with in the morning, a low dose, and then increasing it. And by the time he got to 2 milligrams in the morning, he really was back to himself, which was a much more manageable kid. And he stayed on the sertraline. He stayed on the sertraline, but what often happens is they're on the sertraline and the guanfacine, then things get worse, they can't live this way, and then the choice is, do we wean the guanfacine and then add the antipsychotic, or do we add the antipsychotic and then wean the guanfacine, right? So if parents are able to tolerate weaning, it's preferable because then he'll only be on 2 medicines. But if it's gotten to a point where they can't, then we don't. We put them on the on the Abilify or aripiprazole, and then we wean the guanfacine after that. Sometimes the guanfacine, a little bit of guanfacine is still a helpful layer of treatment, but you know, no one wants to be on 3 medicines if they don't have to. I would rather you be on 3 medicines of some sertraline, some guanfacine, and a lower dose of Abilify than only on 1 medicine and be that a high dose of Abilify. Higher doses of Abilify, much more side effects. So it's uncomfortable when you first do it and for the first couple of decades, but it gets better. Okay, so moving on to a slightly different topic, sexual relationships. I know this is one of the things that changes in teenage years and that it doesn't come up in most of our autism talks. But there are lots of things changing. The social aspects of sexual development and expression. You know, how do kids with autism manage that, right? So I've had kids who stare, who don't get that it makes the other people uncomfortable, and we have to put in a rule. You look at someone for 2 seconds and then look away. The 2-second rule. There's the sensory dysregulation, right? Not liking to be touched or liking to touch, right? So there's that piece in teenagers. The rules about sexual behaviors can be tricky. I don't know if you've had kids with public masturbation or who drop their clothes with autism, and it's a problem and it happens. And I think it has to do with some impulsivity, but the lack of social understanding of how, right? And very little gets as much of a response from your school community as public masturbation, right? Then you're now reinforced because now everybody's right? So I think we see some of that. And then, of course, we have the risk for abuse that we worry about in these kids who often have someone, a care person, an adult person, maybe alone with them in the bathroom for supervision or monitoring, but no one else is there, right? What is the risk for that? So there's lots of challenges when we think about both healthy, typical, and unsafe sexual activities in teenagers. There's also an interesting caveat about sexuality that boys and girls with autism are more likely than their non-autism peers to be gender non-conforming, and they are less likely to identify as heterosexual. So even if they're not gender non-conforming, if they have to choose, they're just sort of less likely to identify heterosexual. So, I think there's lots of interesting theories about that. But if we think about how socialized gender development is, it starts to make sense if you're not someone picking up on that it doesn't, it might not be part of your identity development. So, it's worth knowing about. There is sort of a whole research piece that people look into. They're more likely to have siblings who are transgender, siblings of kids with autism. So, it's a whole thing now. A whole area that we are starting to recognize as something we need to understand better.
So how do you counsel them? Who counsels?
Right. So how do we counsel them?
And do they respond to that?
Right. So I think that our job is recognizing the increased risk and that we need to be aware of it and think about it. I think we're aware and thinking for all of our patients. But I think specifically the kids with autism, not only should we be thinking, but we shouldn't be forgetting. Because I think this sort of thing gets lost when you're so engrossed in the rest of the autism discussion. So I think for us, it's not about counseling them. It's about recognizing it, asking the questions, and going from there. And I think your referral sources are going to be similar to the ones you have for kids without autism. However you're managing that would be similar.
When teaching parents to recognize when these issues of sexuality begin to emerge, or developmentally what to expect, when to expect it. So a lot of parent guidance, I think, about observing, identifying and then managing this normal developmental thing.
If the teen also has an intellectual disability, that's adding another layer of challenge. We give very conflicting messages. We say doctors or aides are the ones who can touch me, help me in the bathroom. No one else touches me. I don't touch anybody else. Well, hard to develop a sexual relationship if that's the rule. Now, maybe parents at some level don't want them to develop a sexual relationship for safety, but plenty of people with intellectual disabilities want to have a sexual relationship at some point. They're not recognizing themselves in the media, so they're not seeing it there. They have often smaller social circles, and often they're always supervised. So without revealing anything, you can think about your own life history. How did you learn anything? You had some experiences growing up at some point in your life to learn what you have now in your life. You need to have privacy. You need to have exposure. You need to have social opportunities for a lot of that. And so you just start to recognize, I think, the challenges. This isn't the solutions. It's just to help us recognize why. So when people say the teenage years are my most challenging, my question is why? And I wonder if some of these typical teenage challenges get sort of, highlighted in different ways in the kids with autism that we're not always thinking about, and we're often uncomfortable talking about as are the parents. So, I bring it up just to throw out some facts to you. And I think what you do is what you always do, right? You're thinking about the patient needs. Do you think that patients need to have some sort of consideration of development of their relationships and sexuality, even if they have autism? Yes. I think we all think they, right? As opposed to typical kids who also probably have needs, but at least can get stuff from their friends in the media. Not always good, but at least something, right? There's the parent perspective, right? Parents who don't want their kids abused, taken advantage of, right? Have fears about the future. This is very, very raw for a lot of parents and very worrisome. But it doesn't mean that there isn't a need here that we need to somehow tap into. And then, of course, the clinical realities of your day. This is not a conversation in 3 minutes, right? This is not a conversation to take lightly. So I just keep coming back to, what is it when it's a patient needs, a clinician needs, the parent needs? It's your shared decision making. You're using your team to work with the family and think through things and partner. There isn't a right or wrong answer. It's about knowing that this is a conversation or a topic that's important and valuable, and finding the time or the space or the people of where we're going to go with that. So you can't talk about everything at every visit, but this is a topic that maybe bears some attention. So what is shared decision making? It's your process when clinicians and patients work together. You make decisions, you select tests, treatments, and care plans based on clinical evidence, but it balances risks and expected outcomes with the patient's preferences and values. So if the parents don't want to talk about it, you're not making them. But you know what? You know that there is a clinical importance to it, and so you're planting a seed. And that's okay if they don't want to talk about it. Many parents say, oh my God, I'm so glad you mentioned that. I've been worried about it since he's 4, right? Okay, apparently you want to talk, right? And so I think it elicits the conversation. I think you can recommend a social safety curriculum. This is an example of one of them. It's actually Circles. The iCircles is the iPad version. I think I cut and pasted it from my iPad. And it's a curriculum that teaches very concrete rules about relationships. You're the purple circle. I'm my purple circle. I'm the only one who decides who touches me and who I touch. I am valuable and I'm important. The blue hug circle is like the front hug. That's only for my immediate family and sweetheart, which ends up being a good word, even though it seems antiquated, because sweetheart can be sexual or not. Sweetheart can be homosexual or heterosexual. Sweetheart can be, it seems old-fashioned, but it works. And it sort of goes progressively to the stranger space where we really don't talk to strangers and we don't have anything to do with them. The wave circle are, people, I don't remember if the mailman, the poor mailman, is either in the wave circle or the stranger circle. I think in the wave circle. And you wave, but you don't really have much to talk about. If you do, it's only about the thing you know them through. So the mailman, you only talk about the mail. I've seen families get social skills, safety, or even the Circles curriculum on the IEP that forces the school to learn it. It's pretty accessible. Is there data on what percentage of children on the spectrum have a parent on the spectrum? I don't think that there is real data. I certainly think that it's higher than the general population. And what we know is what the next sibling, right? So if you have one sibling with autism, the next sibling has a 20% risk to have autism, which sounds high, 1 out of 5, but 4 out of 5 won't. So that's sort of the other side of math. But that's a good question. I think that I had one dad, we diagnosed the second kid, the first son, and then the daughter. And I said to him, how are you? He said, fine. And I said, well, how are you doing with now having another child with autism? And he said, emotion isn't my best thing. That's why I've never connected with you, right? I don't think he's ever been diagnosed. He's a lovely man and totally understands his children. So it's interesting. So anyway, that was a question. So I think social safety is one practical thing that parents can ask for on the IEP. Do you think substance use and teens, do you think substance use is more or less likely in teenagers with disabilities? Let's go with autism as the disability. You can think about the role of intellectual disability in there. Talk amongst yourself for a minute or two and let us know what you think. says it depends.
Okay, now we're good.
Sorry. Okay. So, Springfield, you said it depends. It depends on what? Tell us more what you're thinking.
If untreated, more likely. If autism,
Can you hear us?
Yeah. Go ahead.
Okay. The providers here think that if it's a type of disability that, let's say, is an ADHD untreated, that child is more likely to use substances than a child with ADHD, severe ADHD, which has treatment for ADHD.
so if kids are well treated for whatever they are struggling with, perhaps comparable to healthy community. If kids are not treated, more likely.
Bridgewater, do you have anything to add? You also said it depends.
Maybe it depends on where they fall along the spectrum. The more high functioning, maybe more likely to want to socially fit in, but down the ways of the lower on the spectrum, less likely.
Can I ask Bridgewater, for the clinicians there and the behavioral health providers, is this specific question something you've ever thought about?
We're getting some, yeah, mostly no's.
And Springfield, is this something you've thought about before? Yes. And Auburn?
Yeah, CHA.
Oh, they said they answered.
PCA
Oh, no, they
says
didn't.
yes. PCA says
CHA,
yes.
yes. Uh-huh.
They do think about it. Folks out of CHA, any thoughts on this?
Functioning at, and it wasn't really a thought till we just discussed it.
So my job is done, right? I mean, that's right, is for us to think about this, because I think these are things that you guys know what you're doing. You've got lots of skills, so I'm trying to add a little something there. And so thinking about it, you won't be surprised, there isn't necessarily a great answer. One study of kids with autism does point out they're less likely to go to unsafe places, less likely to have social influences. There's more adherence to rules, and that the rates of substance use are generally lower, but they're not actually statistically different in the studies. They're just generally lower, which means maybe they're not so low. If they're not statistically different, they don't seem to be higher. And then as you also sort of intuited, if that's a verb that I can use that way, a Swedish study did show that the rate the rate was 2.2 times more than the general population with autism. But when they broke it down, if they had ADHD, it went with their autism, it went up. So just like you were saying, it goes up with ADHD, right? I don't know that they looked at treated or not treated. I just can't remember. But look, with intellectual disability, now it's not worse, right? And that goes back to being developmentally less, right? You might not be in your risk-taking phase. You might not be socially with other kids doing it, right? You might be more supervised, things like that. And then it seems like the ADHD and intellectual disability sort of balance each other out if you've got all of them. So I don't think there's any final answer to this question, but people are starting to look at it. And I will tell you that the ASAP program has commented, they see kids who are atypical, who haven't necessarily been diagnosed. They certainly see a disproportionate amount of ADHD, of course. So I think it's worth thinking about. These are kids we shouldn't forget to do our screening. We shouldn't just think, there's so many other priorities. This is not something we should be ignoring, because it seems to be, real. We are less concerned with intellectual disability. But again, you're coming down to your shared decision making. Are you going to spend your time on this when there are so many things to do? And I think that's where you're asking parents, you're asking the kid, you're getting a sense of what are our priorities here. And this does become part of a bigger transition process that you have. So transition, right, is this time when young adults move from pediatric to adult health care. Parents call it the black hole, or falling off a cliff, but it matters. because 90% of kids with special health care needs are going to survive, and good transition does enable them to contribute more to society at whatever level they can, rather than being dependent. There's a joint policy that came out last year where it really focuses on the importance of being youth-centered, focusing on self-determination and differences, recognizing there are vulnerabilities, but that we need to have early and ongoing preparation. We need to be better coordinated with the adult providers. We know that, and we don't necessarily have systems in place to do that. And also that there's a fair amount of cultural differences and health inequity that also plays into this. So the 2016 National Survey asked the questions that they consider the important pieces of transition care. Did you speak alone to the doctor or other healthcare clinician during your last regular visit? Did they work with you to gain self-care skills or understand changes at healthcare at 18? And 3, did they talk about eventually seeing doctors who treat adults specifically? And 83% of youth with special health care needs and 86% without did not meet these 3 things. So we're all doing our best, but I don't think any of us are kidding ourselves that we are great at this. I set a transition policy where everyone, you should start talking about transition at 12, and then I couldn't do it. It's really hard.
Yeah.
They feel too young, but parents tell us that they want to start preparing 10 years ahead of time. If their IEP ends at 22, that makes it 12. It's just really hard. So again, we do our best, but we know what the obstacles are. We don't have a great person to transition to. We don't feel like we necessarily have the staff and training. We don't feel like we've got the tools. We don't feel like we're getting reimbursed. And so most of us don't do a very good job of this. There is some increasing evidence to support the fact that we really should, that if you get good transition care, there's an improvement in adherence to care, an improved perception of health, quality of life, and self-care, increased attendance at adult visits with less time between your pediatric and your new adult visit. And some of the studies show decreased hospitalization rates, but not every one. I think it always felt like the right thing to do, and now there's finally some evidence.
And is this evidence equally strong? This is kids with special health care needs and without, right?
Yeah.
This is a meta-analysis, and it had 43 studies that met the criteria for a good study. And I think it included everyone, not just the disability population.
It's a challenge all around.
Yeah.
No, and I've seen in some offices some very credible information from some organizations we would all have, faith in, that, big poster in a waiting room about transitions. And, from this credible organization, started much later than I would think. I would think it much more 12 in terms of, do you know the name of your condition? Do you spend time with a doctor? You talk about, there's a lot of, those foundational sort of blocks that you can build to the point where you're actually way before you actually transition.
Parents have a hard time let the kid come by themselves. It's so hard, even a teenager, and they want to be there even when we are examining. You have to say, no, please, you have to wait. I have to see by themselves, but it's very hard. But I did go to one of the transition session at Children's, and I learned how important, but the biggest difficulty is finding who to refer to. Not many internists or adult or family practitioners in our area where we can refer them to.
So the issue is it feels like there aren't places to refer them, but that we all agree theoretically this is important. I'm thinking more about this paper. It definitely was not just disabilities. It had all chronic medical conditions in it, but I can't remember if it was also without. But I do remember it was not just disabilities. So, what this new policy statement really focuses on is infrastructure, making transition questions part of your routine care, part of your templates, having QI projects that really hold you accountable to it, articulating the roles in your office, so that's where your care coordination becomes very important. Not that it's not important in other places, and then integrating it, thinking about it not just in terms of healthcare and going to an adult provider, but other things, education, guardianship, thinking about it as a whole person topic. And then for the recommendation is for us to, be able to have more time to consult with adult providers. So the adult provider issue, I'll tell you what I think most people do is parents ask their own clinician if they will take their child as a patient. And more often than not, the adult providers say yes. And adult providers generally don't say that I don't want to take the patients because I'm not interested in autism or I don't know about intellectual disability. They feel like they can learn about it. Their concern is that they don't have systems in the office to support their needs. It's not that they don't want to take patients or they can't do it, but that they have longer visits, maybe the first or the end of the day. They don't have systems in their office for people with special needs. And so there are recommendations that there should be CME training, which of course there are, that Got Transition, is a really solid website with lots of information on it. We have a program offering a collaboration with the West PPOC practices on transitions for 18 and over with autism diagnosis. So we have a program. So PPOC has a program. Who?
This is Springfield.
Who has the program?
Springfield's saying this. If you guys want to unmute yourself, talk about it a little bit. Just say Western Mass.
Sorry about that. No, it's not that PPOC has a program. It's a program in the community who works with transitions, offering to collaborate with the PPOC practices in the West to help them with this because it's huge for everybody. So I just thought that it was worth mentioning that anybody who is connected to your presentation and is on the West, that we have this option.
Great. Thanks, Maria.
Great. So what I will say about the Got Transition website is they have information for you, for clinicians. Here, I have it here. If you go to the gottransition.org website and you go to the tab Practice Resources for Providers, there's like a whole section on coding and billing. We are clearly underbilling and undercoding for what we do in this. Now, I don't know if that means we'll get reimbursed for it, but then you can ask PPOC to advocate at the insurance level to get the reimbursement. But there are lots of things I think we're not doing that would actually bill for some of the time. I think one of the easiest things, well, not easy, but one of the first steps that's at least concrete is at least having a healthcare transition policy. When people come in and they say, how long can we be seen here, that everyone has a generally prepared answer, hopefully a similar answer. Someone once said, we don't first tell kids that they're going to college when they're in 11th grade, right? We actually have been talking about it for years and years about going to college someday. Talking about healthcare transition, when kids are 17 is not what feels comfortable to parents, right? Parents cry their last day. One family told me, I feel like it's the end of his childhood. Right, it's a really big deal. They are committed and connected because you have taken care of them and walked with them, through this whole journey, and it is a tremendous loss. But I always say to parents, I just don't know what to do when you come in with erectile dysfunction and adult issues. I have to Google it. I don't know what to do, and you can do better than that, right? And so I tell them that they deserve a better care than I can give. And they're like, no, but yes.
Yeah, one of the teen moms said, he's eating, he's in the kitchen, he's sitting there crying. Why are you crying? I won't be able to see my pediatrician anymore.
It's a loss. We're agreeing. It's a loss. On the other hand, it's an opportunity to learn to tolerate transition, right? There are going to be many losses and many changes over time. This is just one of them.
I used to stop at it. Now I see the one.
Yeah?
Somebody from Bridgewater has a comment or question. Go ahead. Speak up loud.
Is there any association between obesity and autism? I've been asked that question by parents.
Could you hear that?
No.
The question is there any association between obesity and autism that this provider has had several parents ask her this question?
Yes, there is an association between obesity and autism, independent of antipsychotics. Yeah. I don't know that there's necessarily a single answer about why or what to do about it. But absolutely, I think you're seeing something that there's a literature about. And if you go to the Autism Speaks website, there might be some parent toolkits that can help with that. Also, exercise, interestingly, has an evidence base as an autism intervention, which means I've actually gotten people to get it on the IEP as one of the things that they have to do during school as a treatment for their autism. So talk about two birds with one stone. Getting more exercise to help with the behavior, and the obesity is another thought I'd have.
This discrete trial, like the ABA, you talk about like.
So ABA is one evidence-based intervention, but there are many evidence-based
So when you
interventions.
say like not doing M&Fs, right?
Not doing M&Ms,
yeah,
exercise.
So, yeah.
Well, because exercise in itself is calming, right? It can treat depression, it changes your neurochemistry. And so for whatever reason, there is an evidence that exercise can improve some behaviors in autism.
Allison, is there any percentage risk of autism and obesity? You know, the associated risk?
I don't know. I don't know a number, but I can look it up.
Thank you.
Okay. So, you know, we think about transition. I just want to take a minute. I know we're running out of time. That vocational assessments are just part of a transition evaluation. They only look at the job related skills and interests, but there's a whole lot that goes along with the life transition. The transition evaluations look at tons of stuff, formally and informally. The vocational is just related to the job. So you can actually be asking the school to do a transition evaluation and a vocational evaluation. You'll get varying quality, but it's worth asking for. I think that there are plenty of places to find out about guardianship online. It is not the only option. It is the most restrictive method for the parents to have full decision-making power. You can have a joint trust or fund. You can have power of attorney, conservatorship. I mean, there's sort of lots of options. And so I never tell people what to do. I always suggest that they get legal consultation from someone who has more expertise in the options. Whoops. Here are some, okay, sorry. Here we go. So what are you doing in primary care? Make sure you screen for substance abuse. Try to talk about sexuality. I refer parents to a transition conference where they can get a lot of content around guardianship and vocational options and living options. And we are supporting them around transition, but there should be a transition specialist at every high school. And I refer them to a special needs attorney. If they can't afford one at transition conferences, there are often people that have 15-minute consults, or you can get a free consultation at probate court. Often they have a day a month or something. You have to, be organized. And then do they have Department of Developmental Disabilities case manager? They might not have done anything for you all these years, but starting at 18, it changes dramatically, and they often do much, much more at 18. So here are some resources for you about those topics, and then more websites about transition, special ed law, parent information. This is for national tax if you're not in Massachusetts, the last one. And so just reminding you of the importance of shared decision making. Sometimes it feels like you didn't do anything, but you did, because you validated, you listened, you joined them. And to parents, that's often our value to them, is that they're not alone in all of this. Sometimes I actually document in the chart through a shared decision making conversation, we decided to consider these options and regroup in the future. And then I feel like I did something, right? So anyway, so that does bring us to the end. I've got some resources for you. I think if you go to the up-to-date articles, they're updated every year. Oh, you're welcome for these resources. So these are some of the resources we talked about. And that brings us to 9:02. Sorry for going 2 minutes over, but it was very nice to be here.
And these slides will go out, so all the resources will be in the slides that you can see. So thank you all for participating in this 2-year learning community. And like I said, it's just starting, okay? So we'll follow up with Survey Monkey, all of the coursework information, and these slides.
So you can get the slides, I can save them. So
Yes.
can refer to.
Yes.
All right, great. All right, folks, take care.
Thank you. Thank you. Can I This is
What do we do
beyond
first?
pediatrics.
Stop share or stop
Yeah.
recording?
Autism is relatively newer diagnosis.